Hi, future CRNA. It's Jenny here, coming on with a short disclaimer for today's episode. We got pretty heavy into pharmacology in today's episode, so I wanted to come on here and just make sure everyone's well aware that while I am sharing with you what I know to be accurate, it doesn't replace your responsibility of you to confirm accuracy of everything I go over today. I also want to let you know that this is based on my own personal experience practicing open heart, and it doesn't necessarily mean it's going to be your experience. And a lot of things that we do sometimes in anesthesia are not necessarily going by the textbook. So again, some of this is opinion or preference-based practice. And so I encourage you to take responsibility for your own practice and to make sure you have a thorough understanding of all of these techniques and drugs and the understanding, so that way when you go into your open heart rotation, you truly understand why you're doing and making these choices, not just because you heard it on Jenny Fennell's podcast. So I hope with that, you guys enjoyed today's episode, and let's get into it. Hi, future CRNA. Welcome back to another episode of CRNA School Prep Academy's podcast. My name is Jenny Fennell, CRNA, and your host. Today, we're going to go over a special area that I love, which is cardiac pharmacology. And so, as some of you guys may know who have been around for a little while, I do have a background in open heart anesthesia. I love open heart anesthesia. So again, my passion for this is there, and I'm happy to share with you guys some of the knowledge I have gained over the years. And simply today, I kind of just want to run through some down and dirty cardiac drugs with you guys. I'm not going to go into the full cardiac, or not cardiac, but full pharmacology lesson plan for you guys. I just simply want this to be an overview, so that way, if you're getting ready to start your open heart rotation, you kind of are familiar with some of the more common drugs that you will use in your rotation and maybe how they work on a pretty basic level. So if someone were to ask you, they get the gist that you know what you're getting yourself into and that you understand what you're doing. I think that's kind of key when you start your specialty rotations is, you're not going to fly in there as an expert, and you shouldn't expect yourself to, but you should really have a good base and understanding of the types of drugs you're going to be using, the mechanism of action, and just maybe some of the key side effects to look out for, or potential things that you could come up if you're using those types of drugs, and also knowing how to dose them correctly. So again, this is just meant to kind of give you guys a good overview of various cardiac medications. Also keep in mind that no matter where you do your hearts, you're going to see a slightly different technique. And so I can speak to what my experience is, but I also know just from my training and talking to CRNAs who do open heart at other hospitals, that every system seems to have their own way. And, some places really routinely use Nitro. Other places do not. Some places routinely draw up certain drugs, while others do not. Some places practice opioid sparing techniques, even in open heart. Again, so I'm just telling you all this ahead of time, because knowing that this may not be the standard based on where you go. But I'll go ahead and jump into what I'm familiar with and share with you guys what I know. All right, so let's start off with some drugs. I tend to, when I do my cases, when I did do my cases, I would like to organize things in a way that I had my uppers, my downers, my narcotics, so I had everything kind of labeled, organized. I would even go to the extent, if I had, a syringe of Neo and Ephedrine, I make sure I label them differently, and especially Epi. So if you have Epi, Neo, and Ephedrine, they're all purple labels, so especially if something were to happen, you need something quickly and you have to make that choice, what drug you want to use. You want to make sure you have those labeled differently. So that's one of the first pieces of advice I could give you guys. Like for example, Epi typically was purple with a black line on it, but I'd put one sideways horizontally, and I'd put one wrap it around the syringe. So I had two purple labels on that syringe of Epi. And then for, my Neo, maybe I went horizontally with that one. Maybe for my Ephedrine, I went around the base all the way around with my Ephedrine. So literally all three purple syringes were labeled slightly differently, so I could easily pick them out if I were to grab it in a pinch. And this is, again, just one way to kind of make sure that you're being vigilant and safe. You always still want to make sure you're reading your labels and checking things before you push anything. But for me, that was one more double check method that I used to make sure I was grabbing the right drug. Same thing goes if you have a couple different types of narcotics or really anything that has the same color label. You probably wouldn't be surprised, because if you've experienced this, again, we kind of get label fatigue. We have all these colors that we're used to. And same with when you get medications out of your med drawer, you're used to seeing, the Zofran with a green cap or a blue cap. And that can change. And so you really have to be diligent and aware of when those types of things changes. But when you have syringes with all these blue labels, you could think you're giving fentanyl and you're actually giving Dilaudid, based on how you have it diluted, if they're in the same size syringe. And where we did open heart, we use sufentanil. So again, just making sure that you're labeling things so you can have a way to kind of double check yourself before you push anything. Okay. Because once you push it, you can't take it back. So we're going to start off with drugs that are considered, I call them downers, just because they bring your blood pressure down. First of which that's very common is Nitro. A lot of patients will even come to the OR who are getting ready to have a cabbage. They'll come to the OR on Nitro at usually just like 5 mics a minute, just a really low dose. Now, a Nitro bottle comes as 200 mics per ml in a bottle. So typically, whether you're going to run it as an infusion or whether you're going to actually dilute it, you want to make sure if you're going to use it as an IV push that you're diluting this, because 200 mics per ml is a lot. And so typically how I would dilute it is I would take 1 cc, okay, and again, you'd want to make 20 mics per. So you would dilute 1 cc with 9 mLs or a total of 10 mLs to make 20 mics per. So if that doesn't make sense to you, what I do, my head math, that to me is easy, is I knock off zeros. Like, to me, that's just the easiest way I can simplify math is if I'm diluting something down 10 mLs, now you have 210. If you were to cross off 2 zeros, now you have 20 and 1, meaning you have 20 mics per 1 ml. And so for me, that's the easiest way I can kind of do that kind of math in my head. And I've also seen people dilute it down to 40 mics per ml. I like it at 20 mics per ml. To me, it gives me more control of how I actually give it. Nitro is very quick on and it's relatively short lasting. The half-life is 2 minutes for Nitro, 2 to 3 minutes technically, based on, the circulation time and the patient and that type of thing. But you can really burn yourself, because think about, if you really need your blood pressure down, but now you have 2 minutes where if you overdo it, now you're hypotensive. And the last thing you want to do, you guys, when you're pushing any kinds of vasopressors, vasodilators, is you don't want the yo-yo effect. You don't want up and then down, up and then down. And yes, sometimes it happens. You do the best you can to avoid that situation, but that's not good for the patient. And it's also very labor intensive for you. And sometimes the more you get into that like up down scenario, the harder it's going to be to actually fix that. And, it can be very distressing, not only obviously clearly for the patient, but for yourself and for the whole surgical team involved, because again, that's just not good. You don't want a up and down type of train track vitals. You want train track vitals. You want like a steady line of vitals. So the key when you're pushing vasoactive drugs is to go slow, go just little increments at a time, pick one thing at a time. Don't mix different drugs together. Like, don't give neo and then, and I'm not saying I don't ever give neo and ephedrine, because sometimes I do, but just be careful. You have to know how the patient reacts to those drugs before you do that together. Don't just initially go for neo and ephedrine, because you don't know how they're going to react. Once you can gauge their reaction, and trust me, all patients react differently to these types of drugs, then you can make that judgment call on whether you need to combine them to get the effect you want. But initially, start small. I promise you won't be in trouble if you start small and work your way up. You can always give more. You cannot take it back once you give it. So the next drug I want to bring to your attention that's very, at least for me, was commonly used in open heart was Clevoprax. This is also known as clofidipine. This is a calcium channel blocker. It's also mostly versus Nitro. And back up to Nitro. Nitro is usually it's mostly a vasodilator, meaning it mostly affects the venous smooth muscle, where the Clevoprax is mostly the arterial smooth muscle. And so what's good about the Clevoprax versus the Nitro is you don't get the venous congestion. You can actually essentially change someone's blood pressure without really affecting their preload, which if you guys understand the heart physiology, which I'm not going to go into today, if someone's already in heart failure, especially with the pump, meaning they're not pumping blood forward, and that's the most common type of heart failure is systolic dysfunction or the pump function, then you can actually worsen someone's heart failure by increasing their preload significantly. So, because think about it, the blood's not able to go forward, so you're just going to pretty much dilate that ventricle even more. So you really want to be careful with preload. You can actually do more harm than good with it. So again, Nitro can actually affect your preload, where Clevoprax does not. So we typically didn't use Nitro routinely in our open heart. Again, some places will put it on 5 mics a minute and let it run pretty much the entire time. Other places, again, and if I was like in a TAVR or something like that, where I would anticipate potentially an acute increase in my blood pressure when I got the valve in place, I would have Nitro diluted, ready to push. But for the most part, in my routine open hearts, I rarely ever used Nitro, rarely ever used it. If I picked a drug of choice, it would be Clevoprax or Clevidipine to help lower my blood pressure. And again, that goes on an infusion pump. I would not recommend pushing that. I can't say that people have not, but in my own practice, it's so quick to titrate that drip that it's pretty easy to not have to draw it up as IV push. You can literally start it at 1 or 2 milligrams an hour and go up to a max of 32 milligrams an hour. And again, there'd be times where I would jump from 2 or 4 milligrams an hour to like 8 milligrams an hour. And within like 10 seconds, my blood pressure was quickly adjusted because it's very quick on. It's very, very quick off. It's going to look white like propofol. So a lot of times I would bring my patient over on a little bit of Clevoprax, and, you know, the nurse would be like, oh my gosh, you're still on propofol. I'm like, no, actually it's not propofol, it's Clevoprax. It's just, it's both made out of that lipid based kind of, it's just a lipid based medication. So it looks white. But because of that, it's quickly hydrolyzed by plasma esterases. So again, it's very quick on, very quick off. The half-life is approximately 1 minute. So again, within 1 minute, half the drug is completely out of your system. So it's a great drug. Again, it can decrease your SVR without affecting preload, and that's Clevoprax. The next one I'm going to point out is Nipride. Now, this is another drug along with Nitro that I didn't routinely use in my open heart, but it is out there, and some places will routinely string it up. I think they have gotten away from that because of how expensive it is. At least that's kind of my 2 cents on that, because it is a very expensive drug. It's also very, very potent, you guys, very potent. So this affects your arterioles and your veins. So it's a vasodilator, very potent. Essentially how it works is it actually produces nitric oxide, and nitric oxide in itself is the dilator. Okay. Another thing you have to keep in mind with Nipride, and this usually only plays into patients in the ICU because it's the longer you're on it, the more risk you have with this, or at high doses, is cyanide toxicity. So because of the metabolite, you know, again, it can produce this cyanide. And so if you're on it for a longer period of time, and I believe it's over like 72 hours, like several days, you can actually have the cyanide toxicity, or it can be shorter than 72 days if you're on high doses of it. And again, patients with hepatic and renal impairment can actually have more significant complications from this because they're not able to adequately remove the metabolites from the Nipride drip. So when you're using Nipride, if you're using it in your open heart, again, it's usually going to be temporary just for the case itself, and may or may not go with the patient over to the ICU. But you start low. I would potentially start at like really low, like 0.25 mics per kilo per minute. Okay. The max is 10 mics per kilo per minute. I have never, ever seen that get close on a patient. I can't even imagine having that kind of a dose on a patient. They'd have to have some severe uncontrolled hypertension to be on that kind of a dose. But again, an open heart, less is more. You always want to go really, really low when you're titrating your drips, and just always work your way to what you need. So again, I would start at very low. So that kind of covers the 3 most common drugs that I saw routinely in my open heart to decrease someone's blood pressure quickly. The other thing that I'm just going to throw it out there. And again, not all places will do this. Some places will actually probably frown on this. So please Don't go into your open heart rotation and be like, well, Jenny Fennell told me that this is what she did. Make sure you're always chatting with your attending your CRNA, making sure you're coming up with a good game plan on how you like to do things. And also, especially if it's like your first day or first week in open heart, just try to be more, you should always be observant, but really try to pay attention to what your attending is doing, what your CRNA is doing, and really pick up on those cues, because that's really going to help guide you into how they like to do things. But I would use gas. So typically open heart, you put them on ISO and you let them coast at 0.6 end tidal of ISO. That's typically how you would run an open heart case. But and don't get me wrong, I did like them there most of the time, and depending on you have to obviously use your best judgment as a patient. How old is the patient? Are they a young person going through an open heart or versus someone who's in their mid to late 80s? So as you guys know, your metabolic demand is going to be different based on your age. Are you cooling the patient versus and having to warm them back up? Well, when you warm up a patient, you increase their metabolic need. So again, you're going to have to adjust your gas accordingly. But we use an adjunct Midazolam, Versed. So again, the risk of recall is very low, especially if you have 0.6 ISO on and you're using sufentanil and you're using Midazolam. It's very, very low. And keep in mind, MAC awake is 0.3. So you still have amnesia on board. And if you think about what you're doing in open heart, you don't really want to use enough gas to cause amnesia, but you want to control their vital signs with other drugs. That's why we use vasopressors, opioids, anxiolytics, amnestic drugs. So again, we're kind of combining all these different drugs together to kind of create a perfect little picture for the patient, because gas can be a big vasodilator, which is again why sometimes I used it. So if we were in a pinch and I didn't have Clevoprax stringed and ready to go, I didn't have Nitro drawn up and diluted, I would use my gas. And now I want to caution you guys with this, because if you have to be very careful with this. This can burn you if you, and don't get me wrong, you have to learn the technique, but remember, flows up, the gas is up, flows down. You're not going to get the gas on as fast. So your flows kind of control the speed of which you get the gas on and the gas off, meaning you can get the gas on pretty quickly and then you get the gas off pretty quickly, but you have to keep your flows up if you're going to get the gas off quickly. So, I would typically increase my flows, increase my gas till I saw somewhat of a change in the blood pressure. And then based on how quickly they were dropping, I would either leave my flows up, turn the gas down, or if they weren't dropping very quickly, I would turn my flows down and turn the gas down, but I would let them hold on to that gas a little bit longer as they gradually coasted down. And I would also be cognizant of it the entire time and be adjusting my flows as needed to either dilute the gas or go back up with the gas. And so that technique worked beautifully. But again, it's something that you kind of have to learn how to do. I don't suggest you go in there and just try to do it on your first day. And also, if you don't see them doing that, I also don't suggest you doing that. If you see them doing it, well, then embrace it and try to learn how to use your gas to control the blood pressure, because it's definitely can come in handy if you're in a pinch. Okay, so let's go ahead and get into some vasopressors, okay? As well as some inotropes, some positive inotropes. So inotropy is the contractility of the heart, if that is not a term that you're familiar with. So a positive inotrope is increasing the contractility of the heart. And then if you have a negative inotrope, it does the opposite. And so one of the most common drugs you're going to use in open heart is epi. So epi affects both alpha and beta receptors. And, at higher doses, it affects more alpha than beta. So the beta is where you get the contractility, and the alpha is where you get the squeeze, where you actually get the vasocontraction. So again, based on what you're using it for, you can actually change the dosing, and at lower doses, it actually can be a vasodilator and a bronchodilator because it affects mostly beta 2 receptors. And so typically, unless we rarely ever use epi for a vasopressor in open heart. I routinely would use it as a cardiac dose, which would be 0.03 mics per kilo per minute. We really didn't titrate that unless based on the cardiac index, we saw they needed more. But even then, we would go up by very, very little 0.04, I rarely ever saw anyone get to 0.06. And that's usually if things were not going well, that they would end up on a 0.06 dose. And that's even still very low. If they ended up, really not doing well, obviously we could take them up to the max dose. But again, on a routine open heart, someone who had really low cardiac output, who needed that just a little bit of support, we kind of teetered them on the line of beta 2, beta 1 stimulation. And so it was still probably enough to give them a little bit of vasodilatory, a little bit of bronchodilatory effect, but also just a little bit of beta 1 to help with contractility. The other issue with things like epi is it will increase your heart rate. And because of that, you're going to increase your O2 demand. And so that's not necessarily good, right? You don't want someone who already has a poor heart function to have increased O2 demand. So you have to be really careful with epi, because it actually can worsen someone who already is, not getting enough, not meeting their metabolic demand with the blood flow and oxygen and things like that. So again, we would use it at a very small dose if we used it. And you also want to remember someone who has physiology like aortic stenosis, you really don't want to whip the heart, essentially is what we would always say. And it's because, they have a very concentric, hypertrophied ventricle, and they don't have a lot of filling space. So if you're putting something like that on epi, they can't fill very well, because usually they're very hypertrophied, their chamber's smaller for having to overcome the increased pressure they need to eject out of the stenosed aortic valve. So again, epi is really not a good drug of choice for those patients. So just keep that in mind. A better drug of choice is Levophed. So the reason why, again, Levophed will give you a little bit of alpha, a little bit of beta. It's a little more forgiving with the heart rate increase. You can still see a significant heart increase with Levo, but not that much considering the low doses that we use. And when I say low dose, 0.02, 0.03 mics per kilo per minute. We rarely ever went up above 0.08. If you're at 0.08 of Levo after an open heart case, you need to be starting to think, well, what's going on? Did potentially, did one of their bypasses go down? Because that has happened. I've seen a patient get moved over from the operating room table to their bed, and they have noticeable SVT or ST elevation. And turns out one of their grafts went down. So that can happen. But if you're ever, again, at a 0.08 mics per kilo per minute dose of Levophed after an open heart, you really have to be thinking, especially look at their SVR. Are you over squeezing them? You really want to be evaluating their SVR before you're just putting them on a high dose of Levophed. Okay, if they're really vasoplegic and you need at squeeze, that's okay. But make sure you're evaluating that. You don't want someone who has an extremely high SVR and you're at a high dose of Levophed and, you're just squeezing and squeezing. What they really need is an inotrope. So, and their pump is actually failing. So you want to make sure you're being cognizant of that, because maybe they need some background epi with it. Okay. And a lower dose of Levo. So again, my suggestion to you is to start Levophed off at a 0.02 to 0.06 mic per kilo per minute. I typically would start at a 0.03. That's typically where I would start, or 0.02, and work my way up to 0.06. But that was usually the range I stayed in, you guys. It was very, very small range of Levo that we ended up needing. And again, assessing, do they need fluid? Assessing, is it because they're dry? You don't want to just keep squeezing someone who needs fluid. So always assess what's causing the hypotension. Don't just start treating it and not knowing why it's what's causing it. Because you can actually do more harm than good. All right, so that is Levo. Next, we're going to go into Vaso. And let me back up for just a moment, because I forgot to mention how you mix Levophed. And I also forgot to mention how you mix epi. I figured I'd throw this in there. I actually think it would be really cool if I actually went through like a anesthesia math with you guys. I have a full course of anesthesia math inside CRNA School Prep Academy, a couple hours worth. But I think if I did like a down and dirty anesthesia math, mental math, I should say, with you guys, I think it'll really help some of you. Because I promise you, math anesthesia is not hard, and it's very routine. You do it all the time, so it becomes very simple. And I love simple. So When you're mixing up Epi and Levo, I promise you it's not as scary as it sounds. Typically how we did it is for like Epi, we would put 4 milligrams in 250 mLs. And whenever you put any drug into 250 mLs, the math is super easy. And I'm super excited to share this with you because it'll blow your mind. Instead of using some kind of, the fancy way of doing math, if you put, let's say 4 milligrams in 250, 4 times 4 is 16. So now you have 16 mics per ml. It's that simple. You times all the milligrams, whatever you put in 250, you times it by 4 of the milligrams, and that's what you get in mics. So if you're putting 8 milligrams of Levofed into a 250 bag, then you're going to get 32 mics per cc. It's really that simple. So that'll always work. That's only what for a 250 bag, keep in mind. But again, kind of nice, easy math for you guys. So back on to Vaso. So Vaso is a potent vasoconstrictor. So it increases your arterial blood pressure. It increases, and essentially how it works, it's actually a hormone, okay? Which is found in the hypothalamus, and it's sent to the posterior pituitary, which is where it's released into the blood. And essentially it kind of can work in your kidneys to help reabsorb fluids, but it's very potent. It's an ACLS drug, so you definitely should be familiar with it. And typically how we would use it, now you can either put it on a drip or you can do IV push. We would occasionally put it on a drip. You don't typically titrate it once it's on a drip. You usually let it kind of just stay at its baseline rate. But if you were to use it as IV push, you typically dilute 20 units into 19. So you take 1 ml, which is the 1 ml of the vasopressin, and you dilute it into 19 cc's of saline, which makes 20 mLs total, which dilutes it down to 20 or 1 unit per, for a total of 20 units in that entire syringe. And you would then push either a half to 1 unit at a time. Again, always start small, push that little half, see how they react, because it's very potent. So some patients react very well to vasopressin, some don't. Vasopressin is kind of the drug of choice if you have a patient who is vasoplegic from lisinopril or any of the prill drugs. It's a great drug for that. So even if you're not in an open heart case, even if you're in a case and someone's on a ACE inhibitor, vasopressin is a great drug of choice if they're not reacting to the neo that you're giving. So keep that in the back of your mind. But just be very, very careful with it. Again, you want to make sure you're diluting it correctly because it is very, very potent. You never, ever want to not dilute that drug. I mean, you have to dilute that drug. So just be very careful with it. If you're putting it in a 50 cc bag, just match, you want to make sure you're putting 50 units in 50 cc's. So it's, obviously it's 20 units per. So you have to make sure one of the vials, you're only taking a half cc from that to get 50 units to put in 50 cc's. So that's typically how we would dilute vasopressin when we're putting it on a drip. Okay, so we're going to go into Milrinone. Milrinone is a phosphodiesterase inhibitor. Okay, so it actually modulates cyclic adenosine monophosphate, or CAMP. Okay, and it's a positive inotrope, but it also decreases your afterload. And so it's kind of a unique thing about Milrinone, again, that you can kind of have both decrease in afterload and a positive inotrope. And typically why it's selected is for the positive inotrope. Not that the afterload is not desirable, but what I will say, at least in an open heart situation, sometimes patients won't tolerate Milrinone, even though it is a good drug of choice for them. They don't typically tolerate it if they can't tolerate the decrease in afterload. So it can be kind of a iffy drug, whether it's going to tank their blood pressure or not. So you, again, have to go very slow with this. We would never, ever bolus it. If you look it up, any kind of textbook, it'll say to give a loading dose. We would never do that because that typically almost always would cause hypotension. So again, we would skip the loading dose and we would start it at 0.375 mics per kilo per minute. And that's where we would leave it. Again, we didn't really titrate it. We just kind of left it there. And if the patient tolerated it, great. If they didn't, then we would have to stop it. So that's Milrinone. Okay. A drug that I want to touch on that's also very common, other than the next most common drug, which I'll get into last, is Ephedrine. And so Ephedrine comes in 50 milligram vials. Okay. The dose per kilo is 0.2 milligrams per kilo. However, I still think that's kind of a high dose, like especially now that I do a lot of pediatric cases. You always want to go low. Like I said before, you want to see how people are going to react. Ephedrine is one of those drugs where you never know what you're going to get when you give it. You could give 5 milligrams to a good size adult and have a heart rate over 100, but from 70, so or you could give 5 milligrams and you could see nothing, or you give 10 milligrams, you could see nothing. Ephedrine is one of those drugs where you can actually kind of get quickly acclimated to it, or I'm trying to think of a better word for that. There's a word and I can't think of it right now, but it kind of, over a period of time, you kind of get sensitized to it. So you don't react the same way. I have seen that happen where initially it works really well. And then you get halfway through your stick and it's like you're giving water. So again, ephedrine is one of those drugs that's a indirectly acting vasopressor, and it works on alpha and beta, but it ultimately works by inhibiting norepinephrine reuptake, which essentially allows more norepinephrine to circulate in the body, meaning it increases your blood pressure. Norepinephrine is a natural catecholamine in your body that increases your blood pressure. So that's how ephedrine works. It helps by decreasing reuptake of that catecholamine. So again, that's what I can say about ephedrine. Again, it's kind of can be somewhat unpredictable in how it can react in patients. So I would start off, maybe just try like 0.1 milligrams per kilo to start. And then you can always give more. Again, say that a couple different times. You can always give more. Once you give it, you can't take it back. And just make sure that you're diluting it appropriately. And again, it comes as 50 milligrams, and you want to dose it, in a good size adult, 5 milligrams, 2.5 milligrams. But in a kid, you really want to make sure you're being very cognizant of the weight-based dosing, the 0.1 per kilo. And I'd even go less than that sometimes, just till you know how they're going to react. Okay, so that's ephedrine. Now we're going to go into the most common vasopressor that you guys are going to use, like it's going to be glued to your hand, essentially in anesthesia. And that's Neo. Okay, everyone loves Neo. Neo's like you have Neo, it's always ready to go. And it's IV push. You can do a drip, that's fine, but I'm going to go over the IV push because that's 9 times out of 10 how you're going to use it in anesthesia. Now, a lot of hospitals now are doing these pre-filled syringes, which is really nice. It's kind of spoils you. But I also think because of that, I think sometimes students get into the OR and they don't realize how to dilute it appropriately, because now, again, they're kind of spoiling you with pre-diluting things and putting it in your med drawer. So, and you should always know how to dilute Neo, because it is an emergency drug. If you need it, you need to know how to use it and use it safely. It comes in a 10 milligram vial. That is not safe. Okay. This is just me, but I've seen people draw it up in a TB syringe. That makes me, I mean, I've seen it done. Obviously, if you do it safely and appropriately, that's totally fine. But that makes me, I don't like that. I really don't like that. I always dilute it, in a 100 cc bag, or you can take 2 10 cc vials and double dilute it. That's okay too. But just make sure that you're getting 100 mics per ml. That's what you ultimately want, is 100 mics per ml. Okay. And so again, when you're giving Neo, it's an alpha 1, okay? And so it causes arterial vasoconstriction, all right? So it's very potent, and again, it comes as a 10 milligram vial. You never, ever, ever want to push 10 milligrams at once. And typically, again, you could put 10 milligrams and 100 mLs, and back to kind of some basic easy math for you guys. I like knocking off zeros. Like that's my favorite thing to do. It's so rewarding to knock off zeros when you're doing math. So, if you have 10 milligrams and 100 mLs, if you knock off both those zeros, now you're left with, or that's if you're diluting it further down. Now you're left with 1 and then 10, which makes 1 or 10 mics per ml. That might've gotten a little confusing, but ultimately you start off with 10 milligrams. Okay. And you're putting it in 100 mLs. Okay. So again, you're essentially diluting it down to make 100 mics per. And you can also make it into 40 mics per. I've seen that also be the dose of choice. And the dose per kilo is 2 milligrams, or 2 mics per kilo is the dose per kilo, if you wanted to know that. It's a very common drug to use. It's a very great drug. You just have to be very careful with it. And always back to you want to make sure you're going slow with it. and making sure you know how people are going to react. Okay. All right. So now we're going to go on to narcotics and benzos, but I'm not going to really go into all the different types of narcotics and benzos. So now we're going to go into fentanyl. So fentanyl, 1 to 2 mics per kilo is the loading dose. I like to kind of do the 1 per kilo, I think, for intubation, if it's not going to be a stimulating case. And especially if you want to get them back breathing early on, I like the 1 mic per kilo loading dose, but you're not wrong to give 2. Just keep in mind how stimulating is the case going to be. You know, how long are you going to have to wait before you have stimulation? Because you could then deal with some hypotension because of it. So fentanyl is a mu opioid receptor. It binds to the mu opioid. Everything is compared back to morphine. When you're looking at narcotics, that's kind of how you can kind of judge how potent it is. And so fentanyl is 100 times more potent than morphine. So keep that in mind. And typically, back to the open heart scenario, we didn't routinely use fentanyl for our open hearts. Every now and then we did, based on, if preference. But typically you would give 1 gram of fentanyl prior to sternotomy. So that's a lot of fentanyl. So, but it just goes to show that, again, it's not nearly as potent as the drug that I was used to using and liked using, which was sufentanil. Typically what we would do when I would use fentanyl in my open hearts is, again, 1 gram prior to sternotomy. And then I would start, after intubation and all that, you would actually, and after going on pump, you would start your mics per kilo per hour drip. And typically that's about 2 mics per kilo per hour of fentanyl is typically what we would use in our open hearts as a continuous drip. So we would actually do Nimbex fentanyl. And again, fentanyl would kind of be left at the 2 mics per kilo per hour, and we wouldn't titrate it. We would still give the gram of fentanyl prior to sternotomy. And that's typically how we would do those cases. And we would leave that on up until the very end of the case. Same with the Nimbex. So duration of action of fentanyl is 30 to 60 minutes. And so that's kind of what, that's probably all I'm going to share with you today on fentanyl. Again, you may or may not see fentanyl used in open heart. I will say it's probably the most common drug or narcotic to use in open heart. I found it to be more labor intensive. Okay. I saw a lot more ups and downs with my blood pressure with fentanyl versus using sufentanil. And so we're going to go into sufentanil next. So sufentanil, the duration of action is 30 minutes. So it's more potent, but it actually is shorter acting for its peak effect and things like, so it just seemed to be a little more forgiving. And again, less swings. I feel like you could control it better, essentially, and control the patient's reaction to pain better with sufentanil. And typically all you need to blunt intubation stimulation is 0.3 mics per kilo. Very low dose to blunt the sympathetic surge you get with intubation. So again, typically for open heart, we would give anywhere from 25 to 50 mics for induction. It comes in a 250 mic vial or a 50 mic vial. If I was doing a carotid, for example, I could use sufentanil for a carotid, and obviously I wouldn't do 250 mics for a carotid, but I would get my 50 mic vial. I would dilute it down to 5 mics per ml. And then you would maybe give 20 mics for induction, and then maybe like another 5 to 15 more mics throughout the rest of the case. So on average, you're giving anywhere from 35 to 40 mics for the entire carotid. And it blunts the cough, so they don't wake up coughing and bucking. They're usually very comfortable. So it's a great drug for carotids. I don't think a lot of people think about that because you have to be careful with it because you can get a lot of apnea. But as long as you're dosing it appropriately and not giving it right before the end of the case, you're going to be fine. And again, just giving someone 5 mics is not going to be so much that they're going to go apneic. Okay. But if you're slamming them with 15, 20 mics, yeah, you're going to get some apnea. So just be cognizant of how to dose it and you'll be just fine. But it's a really, really great drug. It can cause bradycardia, which typically, if you're in a heart, you don't want them to have a fast heart rate and it'll increase your cardiac demand. So we welcome some bradycardia. Now, sometimes people got a little too bradycardic, like in the 30s, so sometimes we would actually have to give a little bit of Robenal, or we would use Ephedrine if they needed a blood pressure support medication. But again, really great drug for pain control. Let me think. So sufentanil is about 500 to 1,000 times more potent than morphine. I know that's kind of a big range, but again, I think it probably just depends on the patient and how they react to it. But it gave me the range of 500 to 1,000 times more potent than morphine. So it's very potent. And that's all I have to share with you about sufentanil. All right, so let's go on to midazolam, Versed, the most common benzo you're going to use in anesthesia. So typically in an open heart, we give anywhere from 5 to 10 milligrams. We typically gave 5. I know a lot of institutions give 10. I think that's a lot because think about it. A lot of these patients are older, maybe have some kind of renal insufficiency, and 10 milligrams could, put grandma off her rocker for well over a week or more afterwards. So I try to think about these patients, even though I know they spent some time in the ICU afterwards, they are typically still going home, within that week. So, are they going to go home and fall and then have maybe, and then I always worry about falls and bleeds because a lot of these patients go home on blood thinners, so I get nervous using Versed, and a lot of Versed, especially in older people, because the last thing you want to do is cause them to go home and fall and hit their head and have something else bad happen. So be aware of that. It's a great drug. Don't get me wrong. I like it, but you got to be cognizant of who you're giving it to and what their renal function is. And just, do you really need that much? Because again, you're going to have gas. Typically what we did is we would give 2 or 3 for induction, and we would give 2 or 3 during the wake up, so when they're getting ready to come off bypass, we would give the other 2 or 3. Okay. Or during bypass, I would typically wait till they kind of came off that way. I'd make sure it didn't go circulate into the pump. Because sometimes some of your drugs get stuck on the side of the tubing from the pump, the cardiopulmonary bypass machine. So that's typically why I would wait. And so again, so if you're cooling someone for an open heart and you're warming them back up, you're going to increase your metabolic demand. So being cognizant of that and giving more Versed for a case like that. We typically didn't cool all of our open hearts. Okay. We'd only do that if we did like a circa rest case. And even then we'd only do the circa rest for max 10 minutes. And so we would use Brevitol, Decadron, ice the head, or instead of Brevitol, we would give a dose of propofol. Essentially, all you're trying to do is cause the isoelectric activity in the brain. So decreasing someone's metabolic need to like 0. They don't have any thoughts going on in that brain. So yeah, it's just be aware of how you're using it and why you're using it. Don't just slam someone with 10 of Versed and think that that's fine. If you have a whole 10 milligrams, you don't have to use it all. So again, we would give 5 typically, but every place does it a little bit different. And so midazolam affects the GABA receptor. And the duration of action is 1 to 6 hours. That's a big range. As I just said, 1 to 6 hours. So 6 hours versus 1 hour. What kind of person are you? How much alcohol do you drink on a daily basis? What's your, this is broken down, the cytochrome P450. You're going to hear that a lot in your pharmacology courses in anesthesia. It's how you metabolize a lot of drugs. And, patients who drink a lot of alcohol or take a lot of different types of drugs anyways at baseline tend to have more of this enzyme that breaks down our anesthetic drugs. And so some patients are very sensitive to it, and it will 1 milligram will make them like amnestic. Other people, you give 3 milligrams and they're like, when are you going to start sedating me? And they're crawling out of their skin. So, but that being said, even patients who are acting like that, who are crawling out of their skin, I'm pretty quickly to give them more as well. But at the same time, they may not remember being like that. Even though they're awake and are acting, they may be amnestic. So keep that in mind. It's kind of like being drunk, but not acting like being awake and in the moment aware of what you're doing. But then like the next day you're like, I don't remember any of that. So that's kind of how Versed works a little bit. It's probably the best relationship I can kind of give you because sometimes patients again will be, asking you, when are you going to sedate me for, a very minor procedure, but you have to realize they even though they're acting like they're not sedated, chances are they're not going to remember that. Okay. All right, so let's get into briefly, because I'm not going to go into this a lot. This lecture's already been relatively long, but opioid sparing, again, is kind of an up and coming technique. It's very widely accepted and used, and it's great. I think it has a lot of benefits for the patient. So just real quickly, if you're doing an open heart with an opioid sparing technique, some of the things they usually do a regional block. One of the most probably common ones, and again, this can vary based on where you do your rotation, but is the SAP, serratus anterior plane block, okay, to help block the sternotomy incision pain. They can also do a pectoralis nerve block, but they follow what they call ERAS, which is not just an open heart, it's for a lot of different types of procedures, but essentially what that stands for is enhanced recovery after surgery. And they're looking for ways to cut down on narcotic use, because narcotics are not benign. They come with side effects, constipation, ileus, it's just overall, and obviously the addicting factor to it too. It's just overall not good for patients. So they do things like lidocaine infusions. Lidocaine infusions are good for neuropathic pain. And essentially lidocaine is a sodium channel blocker. Okay. So, and by blocking your sodium channels, it essentially leads to pain, decreased pain generation, to put it in simplified terms. It pretty much weakens your peripheral nociceptors to pain, and decreases your central excitability. That's essentially how lidocaine infusions work. Now, I will say it has to be an infusion. A one-time bolus of lidocaine, even though it does have some of those properties, it's not going to give you the same effect as an actual infusion where you're keeping your concentration over a period of time the same. So the infusion is really what works the best for that. Then you have your gabapentin, which is also an anticonvulsant. So again, neuropathic pain, it decreases excitability of the posterior horn, essentially, of neurons, which are responsible for the stimulation of pain and modulation of pain. So that's how gabapentin works. Then you have something like carb loading, which is not even a medication at all. It's just carb loading. Well, why do they do that? Because it decreases, patients who fast, they typically have insulin resistance then when they start eating again, and it kind of just messes with their whole metabolic system. Like a true diabetic needs to be careful with carb loading. I know that there's limitations to it, but essentially by carb loading and by not putting your body under that starvation stress, you're reducing your overall stress hormone response generation. So that in itself can decrease pain. And so that's why they do it for patients who, again, are not brittle diabetics. Then, of course, you have your Tylenol and Nsaids. Keep in mind, Tylenol is not an NSAID. Tylenol is an antipyretic and an anti-analgesic, but it's not an anti-inflammatory medication. It only affects your COX-2 receptor, where you have your true NSAIDs like Toradol, which is a non-selective COX-1, COX-2 inhibitor. That is an anti-inflammatory medication. Another quick little tidbit, we got to be when you're giving Toradol, especially if you're giving 30 milligrams, and let's just say your patient's 60 years old, be aware that, Toradol is very hard on your kidneys. You can put someone into renal insufficiency with Toradol, especially if they're older. So just decrease the dose. If you're going to give 15 milligrams. You really can't do a lot of harm with a big whopping dose of Toradol, like 30 milligrams. So in a pediatric population, we do a 0.3 milligram per kilo dose. So that's how we dose it. But again, in the adult, I think sometimes we get so used to just giving standard doses, we don't think about it. So just be aware of that, and also be aware that if you're over 50 years old, you should be starting to think about, should I be decreasing the dose? Even though they can handle 30, maybe I should only give 15, because it's not a benign drug in that sense. So then you have ketamine, which is an NMDA antagonist. Okay. So again, that can, especially if you're giving ketamine, like in small doses, I would say a good dose, like a preventative dose for pain, is anywhere from maybe 50 milligrams to start. And then maybe you work another 10 or 30 milligrams throughout the case until wake up. That seems to be a pretty good, even if it's not 50, maybe you started with 30 milligrams and then titrated in 10 more milligrams throughout the case, and for a total of 50 or 60. I think that's a kind of a good still a small enough dose to where, you shouldn't get, crazy nystagmus or anything crazy when you wake up. I still caution you in using Versed. I think that's a good idea to still use a little bit of Versed if you're giving ketamine, because there can be hallucinogenic effects with ketamine. And who wants to wake up crawling on the ceiling? I don't. Please don't do that to me. I don't want to itch my skin off because there's ants crawling all over me. So it can have those potential side effects. So just be aware that you typically get that more with like an induction dose of ketamine, but it still can happen with low doses. So just be aware. Then you also have Precedex, which is an alpha-2 agonist. Okay. It essentially reduces substance P, which is a neurotransmitter that modulates pain. Substance P is pain. And so I guess kind of it works by decreasing your norepi circulation too. So it actually can cause, not only can it cause bradycardia, but it can actually cause hypotension. And it's also very interesting. You can have kind of like a transient hypertension with Precedex, especially if you're giving a bolus of it. And I recently saw that it does happen. I think it's extremely rare, to be quite honest, because no one that I was even with that day had ever seen it before, including myself. But that actually can happen too. So just be aware that, Precedex is not a benign drug. You got to make sure you're giving it slowly when you are giving a bolus load of it, but that's kind of the gist of how it works. So I know I threw a lot at you guys. I tried to condense it into quick little tidbits, so not to overwhelm you with everything. I hope I covered everything is in good enough form. One thing, obviously, I'm tend to be the kind of person who kind of goes back to things sometimes, and I'm like, oh, did I say that right? Because I'm speaking really quickly and I don't know. But one thing I want to go back to real quick, because I'm not sure if I said this correctly. And the last thing I want to do is confuse anyone here. Is I'm going to go back to my Neo and the 10 milligrams and 100 mLs. So 10 milligrams is 10,000 mics. And so whenever you're figuring out head math, you want to think about how many mics am I giving? So 10 milligrams, 10,000 mics. And so back to the whole deletion of zeros, if you write down 10,000, and then if you write down 100, and if you cross off 2 zeros and 2 zeros on both ends, on the 100 and the 10,000, now you're left with 101. So again, that's 1 cc is 100 mics. And so again, I don't know if I thoroughly explained that or if I got anyone confused. That's the last thing I want to do. So I want to back up and make sure I went over that. Of course, I'm always here. If you have questions, reach out to me, and I can put my email in the show notes if you have any questions about this lecture. I know it was heavy, but I hope you guys enjoyed. I hope it helped somewhat kind of clarify things and what you're in store for if you're getting ready to start your open heart rotation. That's super exciting. And yeah, so hope you guys enjoyed, and I hope you have a fabulous day.